Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. Today, I'm going to be talking about the pitfalls in diagnosing functional illness. As usual, everything I say reflects my own views and not those of the Social Security Administration or any other medical body. Why is it important to avoid making an unwarranted diagnosis of functional illness? Well, usually that diagnosis ends the patient's chances of being approved for Social Security disability. And as they say in criminal court, better that 100 guilty go free than that one innocent be convicted. Dr. Pangloss taught us that it is demonstrable that things cannot be otherwise than as they are, but determining exactly how things are in a disability exam can be quite difficult. One of the issues is that in a functional illness, in the history taking, the patient and the physician are working at cross purposes. In a normal history, the patient and the physician work together to determine the correct diagnosis and treatment. Sometimes that's difficult or impossible, as for example in the case of the infant or the elderly patient with Alzheimer's, but there's no attempt to confuse or deceive. In a patient with a functional illness, the patient is trying to convince the physician that their problems are due to problems with their body rather than problems with the mind. So what are common pitfalls in the diagnosis of functional illness? The first is language difficulties. The patient may have difficulty communicating their problems because English is not their mother tongue. They may be confused or demented, or they may lack fluency in their mother tongue due to lack of education or low general factor of intelligence. As well, it may simply be difficult to describe symptoms no matter how fluent the patient is. As an example, try writing down exactly how it feels when you hit your funny bone. You'll probably have a great deal of difficulty. The second issue is that the patient may have an atypical presentation of a common disease. They may have a common disabling illness, but lack the expected symptoms or signs. When I just finished internship, I knew that if abdominal pain was not located in the right lower quadrant, the patient didn't have appendicitis. After practicing for 42 years, I've now seen appendicitis present in the left lower quadrant and the right upper quadrant, and I'm sure if I practice another 42 years, I'll come across a patient who presents with pain in the left upper quadrant. The third issue is that the patient may have a rare disease, sometimes a disease you've never seen before in your career. I always remember that rare doesn't mean non-existent. It only means that you probably won't see the condition every day or every week. And in the 5 years I've been doing Social Security disability exams, I've seen quite a few rare conditions, including many that were novel to me. The fourth pitfall is that the patient may have more than 2 conditions. In medicine, we always try to find one diagnosis responsible for all the patient's difficulties, but that doesn't mean it's impossible that the patient has 2, 3, or even more conditions. A common example is that in the patient with lumbar stenosis, 1 in 5 of them may have associated cervical stenosis and may have no neck pain. This can cause a confusing presentation where the patient has both upper motor neuron and lower motor neuron findings in their legs. A fifth pitfall is that the patient's disease may present with a lack of the expected physical findings. And here I'm going to use myself as an example. Decades ago, I had a low back injury, and once or twice a year it flares up. When it does so, I have a substantial amount of pain and great difficulty flexing my lower back. However, I have no radiation to the legs, no problems with coughing or sneezing, and most significantly, no lumbar tenderness at all, even to heavy percussion, and no muscle spasm. In other words, except for my limited range of motion, my lumbar spine examination is entirely normal. The next pitfall is that the patient may have been misdiagnosed by their treating physicians. I see this commonly in patients who present stating that they have rheumatoid arthritis, yet on exam they have absolutely no signs of that disease. I'm sure what happens is that the patient goes to their physician with complaints of joint pains and muscle aches and gets blood tested, and they come back with a weakly positive rheumatoid factor. The patient is given a diagnosis of rheumatoid arthritis, believes it, communicates it to me, when actually they have another disease process. So never assume that the patient's diagnoses are correct. A seventh issue is that you may be seeing the patient during a spell where they are symptom or physical findings free. Painful conditions normally wax and wane. The patient will have good days and bad days, good weeks and bad weeks, good times of the day and bad times of the day. This is so characteristic of chronic painful conditions that if the patient tells you they have constant pain, which never changes for weeks or months, they probably have a functional illness. You may be seeing the patient on a good day or at the best time of the day for them, and therefore their symptoms or findings may be minor. The final and eighth pitfall is that the disease may have not read the medical textbook. The disease may present with atypical symptoms or atypical physical findings. Again, I'm going to use myself to illustrate several atypical symptoms and findings. At various times, I've had mild carpal tunnel syndrome in both hands and a left common peroneal nerve palsy. When you look in the textbooks at pictures of dermatomes or peripheral nerve sensory areas, they're always perfectly and sharply delineated and in beautiful color. Nothing could be further from the truth in the real world. In the real world, there's a great overlap in sensory nerves. When I had carpal tunnel syndrome, I'd wake up and my entire hand would feel numb. Because I was a physician, I knew to test the sensation in my little and ring fingers, and I would discover that I had normal sensation in the little finger and normal sensation on the ulnar aspect of the ring finger. However, if I hadn't known to check that, I would have felt my whole hand was numb, and in particular, the ring finger felt entirely numb, and it's quite surprising to see that you have normal sensation in half of it. Likewise, with the common peroneal nerve palsy, I had no foot drop, and you're supposed to get numbness of the dorsum of the big, second, third, and fourth toes. My foot felt entirely normal, putting on and off my shoes and socks and walking around. The only thing I noticed was that the big toe, and only the big toe, felt numb when I washed it. So I hope that's been helpful, and as Candide discovered, if it happens, it's possible.